Good afternoon, everyone. My name is Rosa, and I am the clinical lead for the PA program at Moderna. I am thrilled to be here, especially because I'm going to be talking about two clinical trials that are currently ongoing, and I will be able to share with you where we are. I wouldn't say exactly up to date because the data that I have to present is from August of 2024. It was data that was presented in Japan at SIMD. And the next time that we're going to be cutting the data will be in August of this year for presentation at ICIEM. So I'm going to go over preliminary results of the phase 1 and 2 study, as well as the long-term extension clinical trials. Here is a disclosure. I am a Moderna employee, and of course, I hold stocks in the company, and the rest is the list of all the other co-authors, as well as other principal investigators. I'm not going to go over this slide because I think, the presenters in the morning did a great job talking about the complications of PA, and probably my emphasis is going to be on the life-threatening metabolic crisis, also known as metabolic decompensation events, because that's going to be one of our endpoints. I'm also not going to talk about the propionic pathway because I think, like I said, the other people in the morning had the opportunity to take everybody through the pathway. So the investigational drug is called mRNA 3927. I'm going to refer to it as a study drug as we move along. It is given as an intravenous therapy that it is made of mRNA that is encoding the PCA as well as the PCB subunits. These are encased in the lipid nanoparticle. And this is for the liver into the liver. So here's just a picture of, sort of the IV infusion and how this is encapsulated, is released into the liver. By encoding the PCCA and the PCCB, these subunits, the mRNA has the potential to restore the missing PCC enzyme and prevent and treat the metabolic crisis. So these two studies are both open label. What that means is that there's no blinding, so everybody knows and everybody's getting the drug. The first part, the blue portion in here is what I'm going to be calling as the parent study, and then this is the extension study. In the parent study, this is made of 3 parts. Part 1 is the dose optimization and confirmation phase of it. This evaluates multiple doses, dosing intervals, and the dose selection. The primary endpoint is safety. The primary secondary endpoint is the MDE frequency. There was a planned number of participants, 20. These are all patients 1 year of age and older. Dosing frequency at the time was started with every 3 weeks, then every 2 weeks by IV infusion, and those patients receive up to 10 doses. Part 1 now is completely complete, and the bulk of the data that I'm going to be talking today is really about part 1. Part 2 is what is called the dose expansion, and this evaluates primarily the efficacy of the selected dose. It looks at the annualized MDE frequency. It is planned to enroll 15 patients over the age of 1, receiving every 2 weeks IV infusions, and these patients are going to be treated for a year. The third part of the study is the infant cohorts, in which we're going to evaluate multiple doses so that we can decide which is the most appropriate for this age group. We plan to enroll 10 patients under the age of 1 to receive also infusions every 2 weeks by IV infusion and to be treated for a year. For every patient that finishes any of these parts, then we have the extension study, for those patients that want to continue to receive the drug. And that will continue until there is a marketing approval for participants who then continue on the drug, or if the physicians basically feel that it's of no benefit to the patients anymore, then it can be stopped, or if the sponsor, discontinues the development. In terms of who is included, who is excluded, patients have to be confirmed diagnosis of PA, and this is based on molecular genetic testing. This includes PCCA and or PCCB variants. In a Part 1 and a Part 2, they have to be over the age of 1 at the time of consent. For the Part 2 only, they need to have at least one MDE 12 months prior to coming into the study, as well as having a history of signs and symptoms related to the MDE requiring emergency or hospitalizations for at least 24 hours, evidence of laboratory abnormalities such as metabolic acidosis or hyperammonemia. And in Part 3, they need to be under the age of 1 and a body weight greater than 3 kilograms at screening. Who gets excluded? If at the time of screening, the labs, some of the labs show abnormalities in a sense that they are completely out of what is considered normal range, if the eGFR is under 30, or if they are receiving chronic dialysis, if they have a QTc prolongation greater than 480, if they have a positive pregnancy test, or if they're pregnant already, or if they're breastfeeding, if they have a grade 3 or grade 4 heart failure, history of planned organ transplant, and any other conditions that, in the opinion of the investigator, the patient should not be part of the study. So getting a little bit into the data, I'm just gonna explain a little bit about the table, because I have 3 tables and the 3 of them are sort of formatted similarly. So we have here 1, 2, 3, 4, the 5 cohorts, starting with the 0.3 milligram per kilogram that we started every 3 weeks. Then we did 0.3 milligram per kilogram every 2 weeks, followed by 0.45 milligram per kilogram every 2 weeks, followed by 0.6 and 0.9. So at the time that we finished the study, there was a total of 25 patients that were treated. The age at the time of consent, the youngest one was a year old, the oldest one was 26. In terms of the groups that were treated, between the ages of 1 and 2, we have 7 patients. Between the ages of 2 and 12, we had 9. Between 12 and 18, we have 4, and then older than 15, we had 5. So we pretty much have a good representation across different age groups. 13 were male, and 12 were female. So in terms of the safety, we have that a total number of 841 doses have been given to these patients at the time of August 30 of 2024, with a total patient year of 35. The total number of events as it relates to the treatment emergent adverse events rates, and this is for those patients. These are the adverse events that are presented once they receive one drug, at least one dose of the drug, right? So the total number of TEAEs was 719, with a total number of serious AEs 146, and a total number of drug-related TEAEs 149. In terms of the participants with any TEAE, 24 out of the 25 patients did have. Drug-related TEAEs, we had about 16. Serious adverse events, we have 16. Serious adverse events, drug-related adverse events, we had 6. Grade 3, we have 6. And drug-related grade 3, 5. No grade 4 as it relates to the patients that were receiving our drug. Infusion-related reactions were quite common, as expected, I would say. we had 13, and hypersensitivity reactions were 10. After sharing this with our independent safety monitoring committee, they felt that the safety profile of the drug at the current time seems to be favorable. In terms of the most common treatment emergent adverse events, here we have that the three most common at the top of the list were fever, vomiting, and upper respiratory tract infections. This was followed by diarrhea, cough, COVID-19, rhinorrhea, diaper dermatitis, gastroenteritis, metabolic disorder, rash, tachycardia, fall, nasopharyngitis, pallor, and rhinitis. So overall, after giving 141 doses administered to patients, we saw no dose-limiting toxicities were reported. As I mentioned before, 719 total TEAEs were reported in 24 out of 25 participants. 6 of the 16 participants experienced at least one serious drug-related TEAE, all grade 1, 2, or 3. And all of them resolved with no major measures other than conservative treatment, either by stopping the infusion or by giving Tylenol and observing them. Okay, so here is quite a busy slide, so let me take you a little bit about what all this means. This is a graphic representation of what we're seeing in terms of the metabolic decompensation events. If you can see on the very left here is just to represent which patients were receiving which form of treatment at the time. Then this is just a de-identified number of the participants. Every single line or in between each line represents 12 months period. Here, specifically, this one is the number of MDEs that these patients had prior to receiving the first dose. Then from here, it's like the being part of the parent study, which is the first year, or the ones that only receive 10 doses. And then from there, we're talking about when they were in the extension study. So in terms of what the symbols mean, the colors here don't show, but all those dots represent the MDE events. You see the little triangles. I know it might be a little bit small to see, but the triangles represent the treatment that's ongoing. The little square shows at the end of the study. The diamonds represent the follow-up periods. So as you can see here, at this time, we have chosen already a dose. But we can see that the earliest signal for the MDE reduction started pretty much at 0.45. And then we can see how these continue to be sustained for most of the patients at 0.6 as well as 0.9. And with an overall 74% risk reduction of MDE was observed. So in conclusion, mRNA-3927 continues to demonstrate an acceptable clinical safety profile across different age groups, has been well tolerated in participants with PA at the doses administered with no dose-limiting toxicities, and most participants actually want to stay continuing to receive the drug. We want to express our more sincere appreciation to all the study participants, to their families, to the PA community, and to all the research teams that participate in our clinical trials. The very encouraging results to date from the mRNA-3927 clinical program offers hope for the potential novel approach to bring a treatment to the community of individuals living with this devastating disease. Any comments? Any questions?
So one of the things that I've always been intrigued by this approach is that if you try the drug in a somewhat pediatric population, the liver of these kids continues to grow. So I wonder if you adjust the dose as the kids grow, or if you start with a dose and you just carry on with that. Because I imagine that if you start with a dose that is somewhat effective, a year later that may not be enough because the kid is older and bigger. So is that a problem?
No, the clinicians will have the option to increase the dose.
They can increase it. That's very good. And that's their decision. They just decide by how much. They also decide, oh, I'm going to double the dose.
No. Well, if the dose are 0.25 or 0.6 or 0.9.
Okay, so those are their choices. Okay, good.
Thank you. Very nice, very interesting. I have a quick question for the drug itself, because when we talk about like safety, we always like talk about like the endotoxin level in the drug itself. So, do you have any of the idea what is the endotoxin level in the drug, the product itself?
So, if you want, I can probably, let you know which are those articles.
Okay.
Yes.
Thank you.
Yes.
Thank you.
And we also published a previous data cut from this in the Nature paper in 2024. So if anybody wants more detail about, what we have seen, in other as part of the study, it's already in the public domain. You're welcome.
Hi, that was thanks for the presentation and the update. It's exciting. One of the things I was listening for, which I didn't hear you mention at all, is the mutation data on the patients and the biomarker response, because propionic acidemia, as I think people know, if you don't know this, it's heterogeneous within even within certain small groups of patients, it can be heterogeneous. So you just want to be careful. If it could be that severely affected patients with stop codon mutations, which we heard about earlier, they may respond better to the medicine than patients that have missense mutations that could, you might need more enzyme to fix those patients perhaps. So what did you see in your patients? How many of them had what would be considered too deleterious or stop codon or null mutations? And then what were their biomarkers? It looked like on one of the slides it said age of diagnosis, and it said like 4 months, 6 months, 8 months. Patients that are severely affected usually present in the first few days of life.
Yes.
And I didn't see that. Maybe that's just when they enrolled in the study, but are these, can you comment on that? Because I think it might matter in terms of how you can interpret your results. As I said before, it might be that the more severely affected patients are having a better response. And that's what you want. But you need to look at the data, the metabolites, the enzymes levels, and then also the mutations.
At some point, we look into that, and we didn't really see much difference between the PCCAs and the PCCBs.
No, I'm talking about in a specific patient group. You have two different alleles. You have a stop codon. Are patients with two missense mutations responding better than others?
Right.
Are milder patients with missense mutations, are they responding better? That would suggest something different. What does that tell you, the analysis of the mutations and the metabolites?
Yes, I can comment on that.
You did look at it,
We're
right?
looking at We're looking at it, obviously. Yes, absolutely. Yes.
Okay, thank you.
No, you're very welcome.
Any other questions? Then thank you very much.
You're welcome.
And then